It's Casual Fridays today, and we're going to go through something that we did for a doctor literally 10 minutes ago. And I walk through this with providers on a pretty regular basis. And we start these conversations based on the fact that they're looking for better outcomes. This was a doctor that does a lot of aesthetics, and she wanted to know how and why we would use a biologic. And even though she does aesthetics, she wants to start transitioning into more application of biologics for cartilage-based defects in joints. And she's used PRP, she's used PRF, she's used complex HA, and she's like, well, I just don't understand how or why people are excited about using exosomes and how and why they're excited about using Wharton's jelly. And so we walked this through for her. The Institute of Regenerative Education is kind of a bit of a think tank. It's a place where I post a lot of my videos, but there are probably 450, 460 different doctors there from all different aspects of medicine, and they talk collaboratively about everything from protocols and applications to patient outcomes. It's just a great source of information for doctors where there's no stress, there's no muss, no fuss, and people can get answers for things that they're looking for. Let's do just an easy overview of Wharton's jelly. And I don't think this happens often enough. Wharton's jelly is in the umbilical cord. For any AATB certified lab, these umbilical cords come from full-term C-section deliveries in consenting females. Wharton's jelly was identified by Dr. Wharton in 1950. And Wharton's jelly itself is the structural tissue, as defined by the FDA, that surrounds the three umbilical vessels. Now, what does Wharton's jelly do? Wharton's jelly resists mechanical compression, torsional forces, and shearing forces, smashing of the umbilical cord, twisting of the umbilical cord, and stretching of the umbilical cord. And if you think about it, you've got a 7 to 14 pound baby swinging around on a bungee cord, and all of those forces are pretty common for that umbilical cord during those 9 months of gestation. This structural tissue is so strong that in live births globally, less than 0.5% of births are terminated because of kinking of the umbilical cord. This is completely different than a cord that's wrapped around a baby's neck. In cerebral anoxia, or decreased flow to the brain, right, causes intrauterine demise. That's different than the umbilical cord itself being smashed and flow stopping through the vessels. So it's a very rare occurrence, which means that this is a very robust tissue. Wharton's jelly histologically is type 1 collagen, a little bit of type 2 collagen, 3, 5, 7, 9. All right? Well, if we think about the dermis of the face is type 1 and type 3 collagen. When we think of a knee joint, the articular surface of, say, the femoral condyle, tibial condyle is type 2. The ACL, PCL, medial meniscus, lateral meniscus, medial collateral ligament, lateral collateral ligament, those are type 1 and type 3 collagen. And the question comes, all right, well, why would you use a structural tissue like Wharton's jelly for application of a patient with cartilage-based defects in the knee if it's primarily internal derangement where there's loss of articular cartilage, because that articular cartilage is type 2? There was a really good study published about 6 months ago, and I'll link that study in the Institute of Regenerative Education, that looked at in vivo and in vitro testing. And what they did was they took articular cartilage, which is type 2, they put it in a petri dish with Wharton's jelly. And then they did histologic staining, immunofluorescence staining, to determine the collagenic differentiation present. And what they found was when they mixed articular cartilage with Wharton's jelly, they found new immunofluorescence staining that showed collagenic differentiation of type 1 and type 3, which we expect, but also type 2, which we did not expect. So let's review what we're talking about with collagenic differentiation. Say we're going to use PRP, and we're going to inject a knee joint with PRP. Well, what happens when we inject a knee joint with PRP? First, you get inflammation. Then you get a chemotaxis. That inflammation causes the body's own mesenchymal stem cells from blood, from bone, from fat to migrate to the area. And after they migrate to the area, and all those wonderful mesenchymal stem cells from the body itself are in that knee joint, they go through a process of collagenic differentiation, which means that they adopt the tissue type most prevalent in the region. Now, if you're using PRP or PRF or PRM, or even bone marrow aspirate concentrate, the collagen type, the tissue type most prevalent, is type 1 collagen. So the body's own MSCs will differentiate into type 1 collagen, which is fibrin. I call that limited collagenic differentiation, because you're using a tissue, structural tissue, autologous, that only has one predominant tissue type. You're only going to get limited collagenic differentiation. The body's going to go through the process of healing itself, but when it does so, it's going to predominantly create type 1 collagen, which is fibrin. What's the problem with fibrin? We know from wound care literature that fibrin is broken down in 8 weeks to create extracellular matrix. That limited collagenic differentiation means that you're going to have a limited durability with regard to that application. Now, this is borne out in the literature. When we look at BMAC literature and PRP literature, and sure, there are randomized controlled trials for both, right? But what do those randomized controlled trials say? That PRP, PRF, PRM, BMAC works, right, to relieve symptoms for 3 to 4 months, even after multiple applications. But we don't see long-term data that it's providing statistically significant benefit, all right? There's one randomized controlled trial that demonstrates, 6 months data, but I believe it was 2 or 3 applications. But that's not duplicable. Most people in common practice find that after you inject PRP or even BMAC, there's a tremendous inflammation, right? Patient calls you 24, 48 hours later and says, my knee's twice as swollen as it was and it hurts like hell, right? And then they don't get much better for any longer than 3 or 4 months. Well, conversely, there was a great article published by Timmons et al. This is back in 2022. And Dr. Timmons did a single application of Wharton's jelly and found the application durable, meaning out 6 months. Patients continued to have statistically significant reductions in pain and statistically significant improvements in quality of life. But he also found statistically significant reductions in both narcotic and NSAID use. That I am aware of, no other study has demonstrated statistically significant reductions in narcotic and NSAID use out 6 months after application of any biologic, autologous or allogeneic. This was a great paper. So why use Wharton's jelly? Well, I mean, if you're getting limited outcomes with your PRP, whether that's vampire facial or whether that's application for cartilage-based defects, internal derangement in peripheral joints, this is certainly a consideration. And again, especially if you're not getting the outcomes that you want. With regard to aesthetics, this makes perfect sense. We know that complex fillers, continue to expand. They continue to increase swelling. They continue to propagate in the face, right? And so biostimulants have become a little more sexy. What are biostimulants? They're really just putting in collagenic building blocks and then letting the body do the process of healing itself. Well, you could basically say Wharton's jelly is a biostimulant because it's not a stem cell. There's no biologic activity that's causing all this to happen. It's not reducing inflammation. There's no anti-inflammatory effect like you're looking for with PRP. We're doing PRP for the anti-inflammatory effect. That's actually a biologic activity. That's imparting a biologic activity on a human cell and tissue product. Wharton's jelly is just pure structural. It's a structural tissue that has a function in the donor, resisting mechanical compression, shearing force, torsional force, in replicating that structural function in the recipient, whether that's the dermis of the skin, resisting mechanical shearing torsional forces just with movements of the face, or in something like a knee joint, mechanical compression, shearing forces, torsional forces. Think of anyone that plays any sport. All of those forces are exerted on a large joint. What about exosomes? Obviously, exosomes come from Wharton's jelly. Exosomes being extracellular vesicles, little packets of information, right? Why would you use an exosome in something like a facial? Why would that be beneficial? Well, we know that exosomes do a number of things. We know that they down-regulate inflammation. That doesn't mean they're a drug. It doesn't mean that they are an anti-inflammatory. It means that they induce down-regulation of the cyclooxygenase pathways by working on IL-1, IL-4, IL-10, transforming growth factor beta and insulin-like growth factor. They also encourage angiogenesis because they have the most concentrated vascular endothelial growth factor and they have placental growth factor. Now, there are a lot of clinical trials, there's a lot of experimental use with exosomes on systemic paradigms and even neurocognitive paradigms because exosomes cross the blood-brain barrier. In my precaution to everyone, when we're talking about exosomes in particular, is don't believe the hype. You've got lots of companies out there touting trillions of cells. An exosome, by definition, is 50 to 100 nanometers in size, has ALEX expression, and has CD4 or CD8 expression. It has to have all of those to be an exosome. Otherwise, it's just cellular debris. So when the reps come to ask you to use a brand new product because it's got a great brochure or it looks sexy or they've got a great price on it, you want to know, is that a true blue exosome or is it just cellular debris? Cellular debris's got no activity, right? It's not going to help anything. Now, exosomes also have collagenic growth factors, type 1 and type 3. So when we're talking about cosmetic application, right? Typically we've done vampire facials. Vampire facials, again, just type 1 collagen. Limited collagenic differentiation. How and why would an exosome be better for a facial? Well, let's get into it, all right? Epidermis, dermis, all right? We know that you get dermal fibroblast proliferation with exosomes. That's great, right? That's really good for the epidermis. We know that you've got collagenic growth factors type 1 and type 3, which are the most prominent collagen types in the dermis, so collagenic growth factors that are 1 and 3, that's fabulous for the dermis. But there's another factor that I think is incredibly important, right? And that's growth determining factor 11. Growth determining factor 11 has only been isolated in 2 tissue types that I'm aware of and published in literature. One is the intermediate layer of the placenta, and the second is umbilical cord derived exosomes. What does growth determining factor do? It stimulates tropoelastin. What does tropoelastin do? Tropoelastin is the precursor for elastogenesis? Well, if you want tensile recoil, if you want elasticity in the skin, you want elastogenesis. Why are some providers moving away from complex HA? Why this filler face phenomenon? Because excess fillers in the face with excess fibrin deposition, type 1 collagen deposition, fills the face, literally. And by filling the face literally, it increases the tensile resistance of the skin, reduces the elasticity. With increased tensile resistance of the skin, if you were to do a deep plane facelift, and then you have to pull the skin and get pretty suture lines by the ear and just tucked in behind the ear, how do you do that if you have increased tensile resistance of the skin? Now there's more traction, more tension on your suture lines. If there's more traction, more tension on your suture lines, right, do you end up looking like Lindsay Lohan, who had like the best glow up in all of Hollywood lately? She had a deep plane facelift. Had she a face full of filler with extra tension and traction on her suture lines, and those suture lines were completely evident because they scarred or they keloided, or she had necrosis at the suture lines, maybe her glow up wouldn't have been quite as fabulous. And so this is why some plastic surgeons are kind of pushing back against folks that are getting lots and lots of complex fillers, complex HA, and they're trending more towards biostimulants, in particular biostimulants like an umbilical cord-derived exosome that promotes tropoelastin and ultimately elastogenesis, because now the elasticity of the face is preserved. And if you want to do that deep plane facelift eventually, you're not going to have that tensile resistance at the skin. You're going to get a better surgical cosmetic outcome. This is the conversation that I have with 40, 50 doctors a week. And this is generally what we review. I know it's a lot of information, but if you're interested, hit me up and I'm happy to go through this extensively with you personally. Have a blessed day, folks.